Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast from Pacific Neuroscience Institute. And today I have two guests. I have Dr. Akanksha Sharma. She's a neuro-oncologist at PNI. And I have Maria Kuban-Weitzel. She's an author of the book, You Can't Do It Alone, A Widow's Journey Through Loss and Grief and Life After. Thank you both for joining me.
It's great to be here, Anthony. Thank you so much for having us, and nice to meet you, Dr. Sharma.
Good to be here, to meet you, Maria, and to talk about this beautiful book.
So I thought we could start with you, Maria. If you could tell us the story that inspired your book, and then we'll talk to Dr. Sharma about what it's like to treat people with the condition that your husband suffered.
Yeah, well, I will go back to 2014, and that was the year after my husband turned 50 years old. So we wanted to celebrate big, and we had a huge party with his big extended family and mine as well. And so his brothers, he has 5 brothers, and they gifted us a wonderful trip to Paris. We had both never been, and our young son was 3 years old at the time. And we thought, he's ready to stay with grandpa. And so we went on this amazing trip, supposedly, for us to Paris. Now, we both work. And so at that point, we were kind of ships in the night. He worked mostly during the day, afternoon, evenings. I worked in the morning. So it was the first opportunity we had with each other to be 24/7, side by side. And so it was really on this trip that I discovered some very odd behavior that he was displaying. In hindsight, now looking back prior to that trip, I can kind of pinpoint some other moments where I thought it was odd, but I chalked it off to him turning 50, sleepless nights, starting a new show that he was writing for. And so we get on this plane, we go to Paris, and I start noticing little things. And when we get to Paris, I noticed that he's much more forgetful. He couldn't hail a cab when we needed to hail a cab. And this was so unlike my husband. He lived in New York for so many years. And for him to not be able to hail a cab, I knew right away something was off. And it seemed each day we were there, he got worse and worse. It was almost exponentially happening. By the time we got to the end of the trip, I was really in tears. And I knew something was wrong. And he also knew something was off because he would forget his phone in the most unusual time after I've just reminded him to please grab the phone before we walk out of the hotel, because we may get separated at the museum or whatever place we were going to. And he would forget the phone when I literally just asked him to bring it, things like that. And he was a guy that would be up before me and usually working out or, doing something, a million things before I got up. He wanted to sleep in. That was not my husband. That was me. I was the one that always wanted to sleep in. He would ordinarily plan our itinerary, and he did not do that. So by the end of the trip, I was in tears, and I made him promise to see a doctor when we got back. We thought maybe, I don't know, he needed some kind of new medication for his thyroid. Or worse, I thought, well, gosh, maybe he's getting some early onset signs of Alzheimer's, and I thought, well, okay, if that's the case, then we'll deal with that. There's some new medications, new treatments for that, and we can live with that. It was that bad that I thought it was that. Never in my wildest dreams would I think it was brain cancer. We get home, we make the necessary appointments with doctors, and finally, after you see your general doctor and you get referred to a specialist, he sees a neurologist. And he gives him a prescription to get an MRI because he thought he was depressed, was a sign that he thought was why he was going in. So he gets a scan, and later that day we get a call saying we needed to go immediately to the brain surgery center in Santa Monica. And it was there we found out that he had inoperable glioblastoma, GBM. We'd never heard of that. And it was terminal.
So 2 things. When you said he couldn't hail a cab, what did that look like?
We would go out to the corner and we'd say, we need a cab to get back to the hotel, and he would look and he wouldn't know to raise his hand or to blow a whistle, or he couldn't do it. He couldn't do it. It was as if he didn't remember that you needed to step out on the street and look for a car with the thing that says it's a cab. Things like that. I can remember a time where we were having dinner at a fancy restaurant, and the waiter brings our dish, and it was a full course type of dinner, and he puts a little bowl of it's very pretty, and there's an egg in the middle of it, and it was on a bed of pebbles, like stones. And I eat my little egg, and it's so good. And I look up and I hear him crunching something, and I'm thinking, what is he crunching? The egg shouldn't be crunching. And I look and I notice he has a pebble in his mouth. And I'm thinking, what, honey, that is not to be eaten. And of course, we start laughing about it. And he's like, oh, yeah, you're right. Of course. Why did I put that in my mouth? That's not normal. So things like that.
Now, Dr. Sharma, you're nodding like this sounds familiar to you. Does it?
Yeah, in some ways it does. I mean, I think every patient who ends up with a diagnosis like this has their own journey. As I'm hearing your story and as I read through the book, Maria, like it's in your case, it was gradual, but also it always feels very fast. It happened over weeks and days, and there may be some signs going back. For some people, it's very acute, like they have a seizure and they end up in the emergency room, or they suddenly have stroke-like symptoms like weakness on one side, and they come in to the ER as if there was a stroke, but then we scan them and there's this ugly monster-looking thing in the brain. So for everyone, their journey is a little different. Sometimes it's very subtle, which can delay the time to diagnosis, because if you don't have someone who knows you well or loves you or is watching you constantly, you may miss it. Sometimes their personality changes, like behaviors that were never happening before. I had some patients who became suddenly very disinhibited, meaning they were gambling or drinking alcohol and never done that in their whole life. And you have to have someone who knows you well to recognize those changes. And sometimes we do wonder, is this dementia? Is this a mood change? Is this depression? And that's why one of the reasons we get an MRI, even if we suspect that someone has a mood disorder, if it's presenting at age 50, which is much later in life, we always want to rule out neurological issues. So that was a great thing that the primary care doctor did, was even though they might have taught that, or the neurologist, that it's depression, you should rightfully rule out everything. And often patients don't get a diagnosis because they've just been put on medications or things like that without ruling out the important things.
So you're saying, Dr. Sharma, you're saying that Maria was fortunate because they got to the MRI pretty quickly.
Relatively quickly, yeah. And also that her husband was lucky that there was someone who was there who noticed these minor changes. Someone else, if he had been on a business trip, may not have noticed these things. Or sometimes patients are very good at hiding, because you are embarrassed and you recognize that something is off. So you do your best to kind of cover it up, even though you might be scared. But it sounds like the pieces fell in place where they were able to take him to the hospital and to the doctors right away.
Maria, what was the time period between when you noticed these things in Paris and you got the diagnosis? How long was that again?
It was exactly 2 weeks. So we landed, we made appointments, which, as you know, you can't get immediately. You have to look at the calendar and the schedule. And it was the quickest we could. And in fact, my brother-in-law, his primary caregiver, his internist, was the one that was able to see us right away. And so we were able to make a couple of calls. And so we got Sean into his office pretty quickly. And then from there, he was referred to someone else, and then eventually the neurologist. And like you said, Dr. Sharma, they're trying to rule out so many different things. But luckily, we were able to see the neurologist after that. And so it was exactly 2 weeks after we landed when we got the call about the scans showing those big, gigantic tumors.
And I imagine the thought of brain cancer had never even crossed your mind before this.
Never, ever. I think I had heard the word glioblastoma, on the news peripherally, when we were talking about Senator Ted Kennedy, I think had passed away from glioblastoma, but he was much older. So you don't really associate that with someone who was of my husband's age, who was very healthy, who did all the right things, ate well, he exercised. Never in a million years would I've thought he would have some kind of disease, let alone that.
Writer, correct?
He was a writer by profession, yes. So, he had some odd hours. There were some signs now looking back in retrospect and in hindsight, just some odd behavior in that year prior leading up to. But like I said, we would dismiss it like lack of sleep or writing all night on a television show, which he did for years. And we weren't together all the time. So I didn't notice those things really until we were absolutely together. So I kind of shudder if we didn't go on this trip together, how much longer he would have had to have lived with some of these things that he was trying to hide, really. Forgetfulness, leaving his keys here and there, almost passing out. He told me about an instance where he almost fainted during yoga. And that was concerning, but, we sort of ignored it because he was dehydrated or, something like that.
Dr. Sharma, does this match your experience with, in terms of the timeline, when people arrive in your practice with symptoms like this?
Yeah, I mean, I want to touch on that a little bit. It is so with glioblastoma. They're just for our listeners, brain tumors come in many different flavors. They can come from other parts of the body, which is called metastatic disease or secondary tumors, or they come from the brain itself, which is called a primary brain tumor. And a glioblastoma is a type of primary brain tumor, but there are many different types. And they can range from grade 1 or a low grade tumor to a high grade tumor, which is a glioblastoma as a stage 4, grade 4 tumor. And all of these come from cells that are within the brain. So it's tissue that forms our brain. And so it's what we call infiltrative. It's mixed in with healthy brain tissue. And so how the symptoms start will really vary depending on where in the brain these changes are occurring. If they're occurring in the parietal lobe, you might have problems with function and with knowing how to do processing. Like I need to go out, step on the corner, call the taxi or speak. If they're happening in the language cortex, you might have language issues. And sometimes that's easier to spot. If it's happening in the motor cortex, you might have weakness or seizures. But sometimes it's happening in really subtle areas like the frontal lobe, which is helpful for personality, but they can be very minor things like just being teary or angry, and people put that into a lot of different things. We've had a patient, several patients actually, who had symptoms after they delivered their baby, and it was thought to be postpartum depression. And sure enough, it continued for months and months, and eventually they got an MRI and it was a glioblastoma. Glioblastomas can be really fast versus other types of gliomas. So, whenever I see a patient on that first day, the question they ask is, what did I do? Why did this happen to me? And this is one of the hardest questions, but also everyone without fail asks. And it's so natural. It's so natural for us to want to know why. And it's very important for me to emphasize to patients and their families that it's nothing you did or didn't do. And often that patients have like this sigh of relief, because especially if it's a younger patient and their parents are there, or they're so worried that I smoked or I drank or I did this one thing 20 years ago. And we've done a lot of research to try to figure out why brain cancer occurs in some patients and not in others. And we really haven't found any good reasons, except in some patients who've had radiation when they were a child for other types of cancer, like leukemia, they can develop gliomas. But that's a very small percentage of people. Majority of patients haven't done anything. They've lived great, healthy lives. They've been wonderful people. They've done yoga, they've eaten kale, and they get, this horrible condition. And it can usually, I say it's probably been there for 6 months to a year. We really don't know how long, but that sounds, right with Sean's experience, that things were changing, but just so subtly that it was hard to pick on it. And so many other things can be happening that have the same kinds of things, like sleeplessness or anything like that. And usually we see our patients in the 50s to 70s range. We have several young patients in their 30s, 20s, but that tends to be rare. And same on the other end, 80s tends to be rare. Senator McCain passed away from glioblastoma. He was much older when he was diagnosed. But generally our patients, fall in this range where they're really living in this important phase of their life. They're doing a lot of work. They're balancing work and kids and career and retirement sometimes. So there's often patients in their 60s are getting ready to look into the next phase of their life. And it's just, as Maria, you mentioned in one of your chapters, that is the day our lives change forever. And most patients will say, they remember that day. And sometimes, it's important for me to acknowledge that this is the day that life is going to change absolutely completely, because you're going to get a diagnosis that is incurable. And that's important for people to hear. It's incurable. And in most cases, it's terminal.
You mentioned two terms, glioblastoma and glioma. Would you tell us the difference? And then also tell us, why is glioblastoma, what makes it terminal? Why is it so hard to treat?
So gliomas are any type of brain tumors that come from glial cells, which are types of cells that are in the brain. That's like the simplified way of putting it. And you can have low grade or lower stage gliomas, which can be slow growing, and they can be treated by different techniques, the same techniques we use for glioblastoma. When it gets to that fourth level, it looks really aggressive, it behaves very aggressive, it's growing really rapidly, and that's what makes it a grade 4. If you look at the tumor under the microscope or even on the MRI, as Maria mentioned, these horrible tumors. I always describe it as like a monster staring at me from an MRI. Like, I can tell when I look at an MRI, I just get this gut feeling that this is going to be a glioblastoma even before anything else happens. And then under the microscope, they have bleeding. There's just chaos going on, like things that should not be happening in brain cells. So that's what differentiates it. But what's very tricky is one of my mentors used to say, it's like white sand mixed with black sand. It's all together in the same area. You can't really pick out each of those black sand pieces from the white sand. And so it's infiltrative, it's healthy brain mixed with the normal brain, unhealthy brain. And with other types of cancer, there's like melanoma on the skin. You can go in, take a really wide excision if you need to, put a graft there, but you can get it all out. If you try to do that in the brain, and in Sean's case, it was in a location where you really couldn't go in and snip it out. Is that right, Maria?
That's correct. He had several actually lesions, and a big one was near the brainstem. So that was just an impossibility.
Yeah. So we usually can only do surgery in areas that we know can be reached safely, and we don't want to make the patient worse. So we try to do the safest surgery. Surgery is part of the treatment because we want to know exactly what it is, what its markers are. And then we do radiation to try to stop the growth of the tumor, halt the growth of the tumor. And we have some chemo drugs that we use in some different new novel treatments in the last 10 years, but nothing's really created a significant dent. And I see Maria shaking her head. Our survival rates have really remained very low over the last 30 years. And the first chemo that actually was approved came out in 2005. And since then, 16 years later, we're still sort of in that same era. So, and what makes it challenging, to answer your question, is one, that it's in the part of the brain, so it's hard to take out the unhealthy brain tissue or target it. Two, it's very heterogeneous. What I mean by that is that each part of the tumor behaves a little bit differently. It's very intelligent. We now understand that it sends out these little markers to other parts of the tumor to say, hey, let's change in this way. Let's change in this way. There's like a network. It's a very intelligent tumor. And it's able to control how it mutates. So every time we give it something, a few months later, it's mutated. We give it radiation, a few months later, it's mutated. So it's a very heterogeneous tumor. And then a lot of drugs it's very challenging to get them through the blood-brain barrier. So we can't always treat with IV drugs very successfully. We've tried to treat directly into the brain. That's been really hard. The drugs don't last very long, or they don't have the effect that we wanted to have. So there's just a lot of challenges in making a successful treatment.
What came next for you after you got the diagnosis, talking about treatment?
We aggressively went into, okay, what can we do? What can we do to prolong his life as long as we can? And we asked about statistics, and there's a small percentage of patients who do live a long while past this diagnosis with a grade 4 with glioblastoma, but their quality of life is somewhat compromised for most of them. There's very, very few that can live truly a good quality of life after this diagnosis. So for us, it was just, okay, what can we do? How can we make him be one of the, I don't know, 3 to 5% of the people who can live beyond the prognosis of a few months to, 15 months, a year. And so we were able to have Sean for 18 months. I do think part of that was because he did not get those tumors removed. I've seen from just the few people that I've met who were caregivers to others who had brain cancer, and they were able to resect or resection part of their brain. I felt like they came out of it with new deficits. And Sean, for the most part, really continued to live a pretty deficit-free life. He was able to actually write a short film, direct and produce a short film while he was battling this, going through the various kinds of chemotherapies and clinical trials, or the experimental drugs that are out there, including Keytruda, which has shown a lot of promise for other types of cancers. But I don't know exactly. This is why I wrote the book, because we need to fund this disease. It is not as rare as, I know it has a rare classification, but I don't believe it's as rare as it was years ago. I mean, ask anyone, and for some reason people say, oh, I know someone, or someone's aunt, or there's always someone that someone knows now that I've noticed that has been suffering or has died from glioblastoma. I can tell you anecdotally, when I found the brain cancer caregiver support group at UCLA, when I first started, it was a very small group of us in a small sort of conference room. And I know towards the middle and latter part of my time there, it had grown so large. It had tripled in size in terms of the amount of caregivers that were there. So it's not my imagination. I really think that there are more and more people suffering from this. And there's all kinds of theories as to why there are more instances, but I feel like the government needs to put more money. It's one of the least funded, I'm sure Dr. Sharma knows about this, least funded diseases in terms of research. And so I wanted to write this book to also help spread awareness, so that, if you wanted to donate to a research, that this would be a good one.
Put me in that category. I have a friend whose twin sister died of glioblastoma a year and a half ago. And there you go. Dr. Sharma, what do we know about the incidence of glioblastoma? Is it on the rise? Are we hearing about more cases because of Senator McCain? Are people becoming more aware because of high profile cases like his?
Yeah, that's a good question. When you look at the incidence, it's gradually gone up, as Maria said, in the last 20 years. In the US, in the last year, there were about 17,000 new cases of glioma, not necessarily glioblastoma. Majority of those gliomas are going to be malignant, meaning glioblastomas. So you can imagine that about 9 to 10,000 cases a year. And that's just in the US. So yeah, worldwide, I think, and in the US, we are seeing a growing incidence. And the question that you ask is, why is it increasing? It's not really, we haven't been able to, the same reason why we haven't been able to figure out what causes it, the same things. We looked at cell phones, we didn't really find a correlation. That's a popular one. We looked at areas where people live, it doesn't seem to really correlate. You can live in Montana or California and still have a risk of developing it. I think that part of it is more identification, and our imaging techniques have become much more better over the last 20 years. We're really good at picking up things on MRI that we would have missed earlier, or even very subtle things. So some of my patients only got identified with lower grade gliomas because they had an MRI for some other reason. And also more awareness, that patients are more aware that something is wrong. I need to get evaluated for stroke or brain disease or all of these things. So we are diagnosing more patients. They're still in the same kind of age range for glioblastoma. And there, as Mary said, there's a lack of treatments, there's a lack of funding. There's a lot of clinical trials, but most of them are funded by pharma drug companies and industry, which we're very grateful for. But as a result, a lot of them are focused on their one drug, right? Because you're trying to get that drug through and find evidence for it. We need more trials, we need more funding, we need more information so that we can provide not only treatments, but also ways to improve the journey for these patients. As we, for example, we put in so much in breast cancer that breast cancer journey has become much easier. That is not the case with brain cancer.
It does affect young children too. I mean, I read somewhere about how the number of deaths in children is actually quite high due to glioblastoma and brain cancer. So it could affect anyone. Another reason why to bring more research. This doesn't affect old and young.
Right. I'm an adult neuro-oncologist, but in pediatrics, it's the childhood brain cancer has become the number one cause of deaths actually in the last 15 years. That's because we found such good treatments for leukemia, lymphoma, which used to be more of a cause, and kids don't really get lung cancer or other things like that that's come from smoking. So brain cancer has become number one, and there's some really devastating brain cancers out there that really affect these children's lives. And unfortunately, there are a lot of trials in children that have been really encouraging. And sometimes we take a lot of lessons from the pediatric world to help our patients in the adult world.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation. Maria, how did you decide not to pursue a surgical intervention? And was that a tough choice?
Yeah, it was definitely not our choice. We wanted to do everything we could to try to get those tumors out. We sought several different opinions. We got a second and third choice. We flew to New York and Boston, and we sent our scans over to Duke. And every surgeon we saw, even here in LA, all said that they would not go in there. They would not dare try. That would kill him instantly in the attempt to remove those tumors. So that was not our choice. But like I said, in the long run, it probably helped his quality of life in that sense. It helped to consult with other doctors too, because, in some ways it made this team here work even harder, if you will, knowing that there were other doctors in the East Coast paying attention. I mean, I really think that there's something to that. You have to advocate for yourself. And when you can't do that, hopefully you will have a team of loved ones who will advocate for you and fight for you when it comes to it. Because brain cancer, once you're diagnosed, a part of you is already sort of switching off. And it's unfortunate, but to take in all of that information, even at the diagnosis stage, it's a lot to comprehend. And already my husband was at a compromised state. And so I can only imagine and empathize with those who don't have what we had.
Dr. Sharma, do you see patients and their families talking to different universities across the country, university medical centers across the country?
Yeah, absolutely. Everyone's a little bit different. I think what you mentioned, Maria, about the overwhelming nature of the diagnosis is huge. It's a huge amount of information you're getting. I often tell patients this first month, especially, is going to be the hardest month because every day you feel like you get new information. You should do this, you should do this, you should plan this treatment. We need to move forward with radiation. There's not a lot of time left to breathe. And so in our practice here at Pacific Neuroscience, we really try to walk very closely. We see people very closely the first month or two, like almost every week, because there's just so many questions and so much overwhelming information. We really encourage patients to get the most information they want and to get opinions from everywhere. We work where neuro-oncology is a small world and we all know each other. I know Dr. Clausy and we know the East Coast and Sloan Kettering and everybody, and we want our patients to have the best. And so I think getting opinions is very important. Often patients are kind of frozen, or they don't have the resources, or they don't know how to do it. And so sometimes I'll help patients if they want a second opinion. And we're very fortunate here in Los Angeles to have so many centers, right? We have our center, which works through the Providence Community Hospitals. We have UCLA, which is an academic center. We have a City of Hope. We have USC. We are rich with neuro-oncologists here. But we forget sometimes that most cities are not like this at all. So when I practiced in Seattle, patients would drive from 5 or 6 states to come for care because Seattle was the only city that had neuro-oncology care. And that is also true in, for example, Rochester, Minnesota, like patients travel from all over to get to Mayo Clinic. So it's very hard in most places to get specialized care. Generally, neuro-oncology is practiced by medical oncologists, and they do a wonderful job, but it's actually becoming increasingly specialized. So there is benefit in getting a neuro-oncological opinion. And because this is all we do, we have a different perspective in terms of what is possible and in terms of prognosis. Like we tend to have a more optimistic view because we do see patients who do better. We do see patients who get to that 3 to 5% of long-term survivors. But because it is so hard to get to centers like UCLA and things, a lot of patients are compromised in their care, I feel. And so we're hoping to, one of our group's goals is to be in more community centers, for example, so that there are more trials available. So we're all over Southern California. But to do that in Arizona or Nevada is really what's needed, where there's really no options often for patients to even consider surgery or consider treatment. And this is, in America in 2021, it's very challenging.
Yeah, and it shouldn't be that way. You shouldn't be one diagnosis away from bankruptcy, or first thing people will say is you've got to move to a research hospital, and there are only a handful really across the country. And so I really am so thankful and grateful to the support group that I found at UCLA, because without them I wouldn't have known even to do the things that I did. Because imagine you see these support groups for cancer in general, and it's just really, if you suffer from breast cancer or pancreatic cancer, there's one support group. At UCLA, there is literally a support group just for caregivers for patients of brain cancer. That's it. No one else. It's that harrowing of a disease that it requires that specialized, really focused group to help you through this journey.
Yeah, and one of the unique challenges with brain cancer is that one of my patients has been described it as the robbing disease. It robs the patient of themselves day by day, step by step, personality by personality trait, function by function. And I thought that was such a poignant way of putting it, is this horrible monster that's robbing the person. And Maria referred to the fact that once you get the diagnosis, you're already sort of turning off. And part of the reason why it's so important to support our caregivers is that they're the ones who start really being the primary source of decisions, of understanding what's happening, of helping their patient, their loved one, guide through in a compassionate manner where they're not feeling like they can't do anything, but still having a say in their care. But it's extremely challenging because you are so used to having a certain role in your relationship and your family, maybe as a spouse, as a child, as a parent. And all of those roles are flipped. You're suddenly become completely dependent. Like I had a patient who was very fond of, she used to run the house, and then she had a frontal glioblastoma and became completely disabled. And her husband was like, I never have to worry about my bills or insurance. And now our insurance is lapsing because she used to do all this. And so it was really, it's super overwhelming. And our caregivers they have to learn new skills, take over all the roles in the family, and supporting each other is one way that we can do that. And that's why we really need to help them find each other so that they can support each other. And I've had, through my practice in Seattle and Arizona, like really tried to connect spouses because it is so challenging. And one of the other things is that we know that patients' understanding of their disease is much less because the brain kind of protects itself. The brain protects itself from the true knowledge of what's going on. So patients will keep saying, keep going, let's keep trying. And quality of life changes for that person. And part of it is that we so much want to live. All of us want to live, of course, right? No one wants to say this is done. Yeah. But we don't understand what's going on fully because there's a tumor that's in our brain that's controlling. And so caregivers often have to make those really difficult decisions. And I'm sure you were in that place, Maria, where Sean maybe was not on the same page or had different understanding.
And imagine caregivers who are having to do that while having to work and actually make a living because one of your members of your family now is not able to work. So having to carry all of that weight of having to support financially the household, and then also be on top of the medical care, is debilitating for some people. And so yeah, we have to make some changes in the future and offer services for the caregiver as they continue to do this. Yeah.
Maria, with whom did you interact most in the support group? Was it doctors, social workers, other caregivers, and how did you interact? Were you meeting in person? Was it
All of it? All of it. At that time, it was definitely in person. It was pre-pandemic, so I'm so thankful that I had that available to me. We would meet every, I think it was every other month, if I remember correctly. And boy, that came quickly. And I remember I went to the first meeting. Finally, I would see the posters. I actually think that doctors should prescribe this immediately for the caregiver. I don't think it's an option. I don't think it should be suggested. I think it should be prescribed and must.
You're saying that, yeah.
Must be a must do for the caregiver, because you don't realize the benefits of it until you're in there. And to be honest, even the first night that I was there, I thought it was a waste of time. But I remember how I thought, why was I so stupid to wait so long to go? Because the information that I got was so invaluable. And to this day, I still communicate with this core group. We called ourselves the samurai, the 7 samurai. And without them, they were my lampposts. And it's interesting how someone's spouse died in January. So everyone was ahead of me in terms of the timeline. And so I saw all the lampposts, and it prepared me for the road that I was about to go on. And even with all that preparation, it was terrifying. And to imagine that I didn't have those lampposts, I really honestly don't know if I could have kept it together without them. I don't know. I don't know where I would have been at the end of that.
That is so powerful, and it's so important. It sounds like your samurai really gave you such important advice and to show the step what lies ahead, which is why a lot of people, I think a lot of patients' families tell me they don't want to join support groups because they're afraid to see what's going to happen. And we recently at our center, we started a very specific support group. It's for patients who are in their 30s to 50. So sort of the range that Sean was at in, because it's a very unique group. So it's younger. And as you have gone through, Maria, you have young children. It's a different phase in your life. You're not done living life. You're not close to retirement. You haven't often prepared for those things like long-term care insurance or very practical things. Like you don't even know what a caregiver is and where they come from. Like, I mean, as in like a live-in caregiver.
We had a 3-year-old.
And so it's a very different group. So we recognized the need was so great. And so we started this virtual patient and caregiver support group. And we included patients because a lot of the wives would say, well, I don't really want to, go without him or be without him. So, or husbands would say the same. And it's been beautifully attended, but what's wonderful is, like, as you mentioned, like once they were there, they really hesitated until that last moment where they clicked on the Zoom link. Yeah. But they had the same stories, because what I try to tell them is that I can't understand what you're going through better than somebody who is walking through that same journey right now. I would never be able to understand the same level of pain, the same level of difficulty, even the same moments of joy.
Yes. But even just the day-to-day, practicalities. And the practicalities of living with glioblastoma was so valuable. Hearing them talk about, here's what you need to do. You need to find some cannabis. We talked about that and with the relief that can bring a patient. And so, having to go get a card so I can go get that. And, for my husband, and, things like finding a home health nurse. They don't really tell you the doctors are there to give you hope and talk about treatments, but they don't tell you about how you're going to need to find a bedside commode, deal with incontinence problems or deal with joint aches and the effects of that, and how to find a nurse to give you IV drips because your spouse is now losing so much weight that they're not even drinking or eating. Things like that, that's just not part of the discussion when you go in for your neuro-oncology appointment.
You wish it was?
I do. I wish it was. But a part of it though, Dr. Sharma, is that we had this discussion right before we started. The doctor is in a bit of a gray area, because you want to tell the patient that there's hope. You want to tell the patient that these are the things that are hopefully going to keep you alive. But as a caregiver, you also want the truth, and you want the honest truth about what they're going to expect to see and experience. So for me, I maybe it's the reporter or the journalist in me, but I needed more. I had more questions and I needed answers. And so I would call the doctor, and I was frankly a pain in the ass. And Dr. Klausi, I apologize. I have apologized to him, and he was so kind and generous with his time that you would often wait in the waiting room as a patient and caregiver for your appointment. And I understood why now, after a while doing that, because we waited a long time in the beginning. I'm like, why are we waiting so long? And I get it. It's because doctors really give you the time you want. If you have questions, they don't rush you out of the room. And so he did that for us. And I found his email and he gave me his phone number. I was a pain in the butt. And so he was forced to give me this information, I think. And but it helped me. It really helped me plan. And
I think that's very important. I mean, I think that a lot of our literature from the brain tumor supportive care literature shows us that we already know this. In the last 20 years, we've learned that caregivers have very different information needs than patients. They have entirely different information needs, and they have very different understanding of the situation than patients. Most of the time, they accurately understand the situation, but patients don't. And what's really interesting is that the neuro-oncologist usually is more optimistic than the caregiver. They think that things are going to go much better than they are. And that's understandable, right? Because I want my patients to do well. If I didn't have that hope, I wouldn't do my job. But at the same time, one of the reasons I did a palliative medicine fellowship was that exactly what you're bringing up, Maria, that I had a loved one who went through cancer treatment and end of life. And there were so many unanswered questions, like, how do we give morphine? What are you talking about? What does a suction machine do? How do we change somebody? And there were all these unanswered questions in this. The day-to-day living was so challenging, especially as my loved one got worse and sicker, until we were bedside, just kind of frantic, not knowing what to do. And hospice hadn't really come in. So it can be a very lonely road in that aspect, unless the physician recognizes these needs. And we do have to do better in neuro-oncology in incorporating all this information, I think, and also referring patients to palliative care, social work, counselors, therapists, who can provide this additional information, because it's just such a key part of life, and we don't recognize it. We've been so focused on finding a treatment. We've been so focused on, like, let's get this person through this chemotherapy. But for example, there's a very famous glioblastoma patient, Adam Hayden, who's a huge proponent of palliative care. He tweets a lot, and he said, I would go to my neuro-oncologist and he'd ask me about the chemotherapy. But then I'd go to my palliative care doctor and he would say, what about that itching that you're getting from the chemotherapy? Like, who's managing that? Do you need anything for that? Yes. And then, in our center, we have a clinic that focuses on symptoms, just entirely on symptoms. The whole time we talk about is, do you have support at home for this? And 50% of the time, all I'm doing is coordinating. I have a list of caregivers, a list of local home health agencies, a list of local therapists, so that we can provide support. But thank you for bringing that up. It's so important. And, you mentioned that it is challenging because you're trying to get a plain spoken update about the situation, for example, and you're trying to get other information. And we hesitate, we worry about honesty. Like, we worry, what is that going to do to the patient's mindset, to your mindset? Right. But for some people like you, it's worse to be out in the sea floating without any
Right.
guidance.
Right. I think that's why it's important to, well, I mean, this book is one I thought, I Googled for information. I really didn't find many at all about what kind of journey I was getting on. And so one of the many reasons why I wrote the book, it was a promise that my husband and I made to each other, that it was maybe our role, that I wore a microphone every day and that he was a writer, that maybe it was part of our purpose, was to bring more awareness to this disease. But yes, we need more support for our caregivers. And I wish that maybe one day when someone gets diagnosed with this, that also their caregiver can have someone assigned to them. But we were hoping to try to pair up a caregiver immediately at diagnosis with an angel, or, we call it an angel, or someone like me, someone who has gone through it and can help them at least with the questions that they might be having, and what questions to ask maybe at each appointment subsequently, for them.
Hold back in this book, you've discussed everything from talking to young children to the last moments, and I really love that there was, at the end of every section, there's the grief therapist's opinion that really sort of strengthens it and gives a perspective from a specialist's opinion. But it was just really beautiful that you go through everything and don't shy away from it, because I think it's so important to know about these things, like the last moments of someone's life, and how the day after, when someone's gone, and it's so pain, and you start with that, and it's so poignant and painful, but it's such your life also goes on, like there's lunch, and you have to feed your child and take them to school, and it's beautiful. So thank you so much for sharing all that.
Thank you.
I would say the same. It's clear that this book was written by a journalist, because it's all right there, and it's very well explained and very honest and very authentic. And it's a gift to anybody who's going through, this disease or any disease like it, honestly. I wanted to ask, I heard an interview with Jane Goodall recently, and the interviewer asked her, what's next for you? Because she's getting older, and she said, death. And the interviewer was taken aback and said, what do you mean? And she said, well, isn't it going to be interesting to find out, the answer to the biggest mystery in life? And I'm wondering, question for both of you is, caring for your husband, Maria, and caring for your patients, Dr. Sharma, how has that changed your outlook on death and what comes next, and what role our perception of it should play in our lives?
Oh, well, I ask that question all the time still. I think, I'm still trying to figure out the purpose. Part of the purpose, I think, for us is this book and helping to spread awareness and shining a light to the need for funding and research for this disease. As far as death and my husband, I tell you, he makes himself known to us. I still talk to him every day. That's never going to change. My son and I encourage him to talk to Daddy. And I said, if you listen really hard, Daddy will answer. And he does in his own way. And so I tell people that, talk to your loved ones out loud, and they will respond. I also find it hard to get up sometimes in the morning, like many people. And when people ask me, I still have a job to go to every morning, and I'm the morning meteorologist here on Good Day LA, and I have to smile and let people know, what kind of day they're expecting. And I remember back to what my husband and I had conversations before he died. So in a way, this diagnosis was kind of a gift for us, because we were given a timeline and we were able to talk about everything and talk about death and what life would be like, I thought, and he thought, for us. And he wanted us to be happy. He wanted us to keep living. And so I wake up and I don't want to let him down. Mm-hmm. So I tell my son that let's not let Daddy down, and let's keep going, even though it's hard sometimes. Sometimes it's really hard. Some days are harder than other days. but I feel him and I don't want to let him down. So we keep going and we make more memories. That's what he made us promise. And one day we will be together again and we'll talk about all of this. But in the meantime, we're gonna try to make him proud of us and be happy, and we're gonna choose joy.
That's so beautiful, Maria. I love that in the book you mentioned several times that even though it was such a terrible journey and you wouldn't wish it on anybody, it did give you guys the importance of each day. And I think that it's not about just waiting for death. You know, I do have some patients who get this diagnosis and then they're just frozen until the life changes. It's using that information to try to live your best life in the time you have. And death is a huge mystery, and it might be interesting and it might be fascinating, but we don't know what it's going to be. But we do know that we can make the best of every day now. So I really appreciated you describing how your family did that, and every family has their own way of doing that. I think for me, I just, in my job, there's so much passing away in death. There's so much loss. And I think that the way that I view death now is that I don't see it as a failure. That's very important to me, that I don't want to think that I failed, that the outcome of my failure is death. What would be a failure if it was a bad death, and if it was a painful death, and if the family is left with regret or trauma that is going to continue for the rest of their life. So my goal has really become how that death happens rather than will that death happen, because I think that death is inevitable. And that doesn't mean that I don't have hope for how much time they're going to get. I always hope it'll be more time. But my focus really becomes on how are we going to make sure that when that time comes, you're prepared, your loved ones are prepared. And I have given you the tools so that it's not a horrible traumatic experience that you never recover from, but it's something like Maria, you're describing, that it's something that you can grow from each day and still learn how to find joy. Because I've seen and I've experienced within my family just the effect of a traumatic death. So I think how someone dies is really important.
It's all traumatic. My husband's death was very traumatic, and it will always stay with us. But like you said, it's your perspective and how you choose to see it. And I'm thankful for one of my support group members, because I remember that day so vividly, and I write about this in the book, when we had to make the call to hospice. And that was such an emotional day for me, because I felt like I was giving up on my husband. I felt like we were giving up on him, and that we were calling the death nurses to come. You know, when you think of hospice, you think, oh, they're going to die. But she really outlined it for me. And she said, Maria, your fight doesn't end now. Your fight for your husband to live, you just have to switch it. And you're still fighting for him to live, but you're fighting to make sure he dies the most comfortably, that he is living his last moments in the best way possible. And that's what I did. I fought, I transferred that fight to that. And so I made sure, we all did, our whole family made sure that his last moments were the best that one could ask for.
That's tremendous. I can't thank both of you enough for coming on the podcast and talking with us today. It's been tremendous. Dr. Sharma, Maria, it's been edifying and so helpful to have you both. Thank you.
Thank you so much, Maria, for sharing so much of your life and your family's life. It's been so wonderful to read your story and to see you and talk to you today. Thank you so much.
Thank you for having me here, and thank you for doing your work, because we want you to keep going. We want to find a cure.